Hello and welcome. My name is Caroline Cruz. I'm President and Chief Executive Officer of the Platelet Disorder Support Association. And I'm joined today by my co-host, Mervyn Morgan, Chief Executive Officer of the ITP Support Association. Mervyn, it's great to see you from across the pond, and happy Global ITP Awareness Week.
Thank you very much, Caroline. Happy Global ITP Awareness Week to you as well. We're both delighted to welcome so many of you to today's webinar, which is entitled Your Voice Matters, Navigating ITP Healthcare Decisions Through Shared Decision Making, which has been co-created by the PDSA, the ITP Support Association, and is supported by SOBI.
And shared decision-making has become a popular and important topic in ITP over the last few years. And today, along with our expert speakers, we look forward to delving into what shared decision-making means for people with ITP and how it can help you to navigate decisions about your ITP care.
In today's session, we will discuss the current shared decision-making landscape for ITP, explore the challenges and the barriers to shared decision-making from a clinical perspective, and gain an understanding of how, as it is how people living with ITP currently feel about shared decision-making in ITP care. We have a packed agenda over the next hour as we hear from the various experts in the field of ITP, followed by a series of live polls and a short Q&A at the end, for which Caroline and I will be joined by Dr. Nicola Cooper, who most of you will know. So please do enter your questions to the Q&A chat at the bottom of your screen. You can see that probably now throughout the webinar, and we will answer as many of the questions as we can. For today's webinar, we kick off with, first of all, Dr. Cindy Nunert, who will introduce the concept of shared decision-making and how it impacts ITP care. Then we will hear from Dr. Nicola Cooper, who will share her perspective and experience of shared decision-making in ITP clinics. This will be followed by Barbara Levenik and Daniel Boyle, both from the ITP International Alliance and very respected colleagues in this field. Both live with ITP and run patient organisations for others affected by ITP. They will be discussing their personal perspective and experiences of shared decision-making, and will also share some top tips for preparing for your appointments.
So before we dive into the session, we wanted to formally introduce our expert speakers and thank them for sharing their experiences and expertise. Dr. Cindy Nunert is a pediatric hematologist-oncologist in New York. Cindy received her medical degree from Eastern Virginia Medical School and has been in practice for more than 20 years. She also chairs the American Society of Hematology ASH ITP Guidelines panel. Dr. Nicola Cooper is a consultant hematologist and senior lecturer at Imperial College in London. She runs a research program investigating the causes of hematological autoimmunity. Her team's work has been published in international peer-reviewed journals, including the British Journal of Hematology. Barbara Loverencic is president at the Italian Association, Immune Thrombocytopenia Purpura, AIPIT. Barbara was diagnosed with ITP at the age of 4 in 2010, together with 14 other members. Barbara founded her organization, which is a charity that provides education, advocacy, and support to adults living with ITP and families of children with ITP. And finally, Danielle Boyle, Chief Executive Officer at ITP Australia. Danielle was diagnosed with ITP in 2015, and through her ongoing journey, she identified an unmet need for Australian-based information and launched ITP Australia in 2018, and now ITP New Zealand. As CEO, she regularly advocates for regulatory bodies and key stakeholders to improve treatment access and protocols, provides support, and is the leading source for Australian ITP information for CARES and ITP patients.
So Without further ado, we would like to welcome our first speaker, Dr. Cindy Nunert, who will be introducing us to the concepts of shared decision-making. Over to you, Dr. Nunert.
Thank you all. My name is Dr. Cindy Nunert, and I'm just going to provide an introduction to shared decision-making. So what is shared decision-making? Shared decision-making is when physicians and patients work together, and we put patients at the center of their decisions about their treatment and their care. While we have current clinical guidelines from both the American Society of Hematology and an international working group, both of these really recommend that the treatment decisions are based on shared decision-making between the physician and the patient. When we adequately are engaged in shared decision-making, we're, as clinicians, making decisions on the basis of the clinical presentation of each individual patient. Every patient has unique characteristics in both their values and their preferences, as well as their disease and natural history of their disease, that have to be taken into account. And ideally, through a shared decision-making process, that would consider those values and preferences and also allow the clinician to then align those values and preferences with what they know about the patient's individual history or individual characteristics of their disease to arrive at a decision that makes sense in the context of both of those. But despite this known value, despite the fact that guidelines and consensus documents are really encouraging physicians to engage in shared decision-making with their patients, there's a lot of barriers that exist, and we find that it's probably not happening as much as we'd like in clinical practice. And why is this? Well, we all know that in a busy doctor's office, sometimes we feel as though we, at least as the clinicians, feel we don't have that time to give every patient that individual attention that they deserve. And we try. And I think it also involves, also helping patients before they come to the visit so that we can use that time to have the quality time that we need to really engage in that discussion. And I think sometimes it's also very good when these visits occur, when we know that there's big treatment decisions to make, that those are visits that get set aside with additional time. It's not just a standard routine follow-up visit, but maybe it goes in as, an extended follow-up, and you really align with the physician to give that visit a little bit more time than you would a regular visit. I think we also have to provide really good education. We're trying to empower patients to be part of what can at times feel like a very big and overwhelming decision. So it's our job to give them the right tools, the right education, as mentioned here, the right resources. I think the UK ITP support group has done a wonderful job at providing a shared decision-making toolkit on their website. The Platelet Disorder Support Association has drug handouts and drug sheets available that are written in patient language. And we really need to make these tools available to practitioners and clinicians that are seeing patients. So when we come out with guidelines or we come out with consensus documents and we push and encourage shared decision-making, we can at the same time in parallel say, and here's the tools to help them do that. What we're really looking for is a collaborative approach to ITP care that uses this shared decision-making model. What this does is it empowers you as the patient to express your personal goals, your lifestyle, your needs and preferences to help improve what your physician needs to know about you and your personal experience with ITP. I often say too, this isn't about just what does choosing a medicine look like, but if you're on a medicine, it's also important then to be able to use the same tools to communicate why a particular medicine may no longer be working for you, or why you might want to consider switching medications. So this really is about coming up with common knowledge that allows the clinician and the patient to talk together and interface in a way that really picks the right medicine to achieve the goals that are being discussed. By using shared decision-making, by empowering and providing resource and education, we're ensuring that you have a good understanding of the benefits, the harms, and the possible outcomes of different options. When you can understand these and we can understand your goals, then this is going to support and shape an informed decision about your care and treatment based on our clinical evidence and what we know, but also what matters most to you as a patient. We do know that when people play a more collaborative role in managing their healthcare, they're more likely to choose treatments based on their values and preferences rather just those of their clinician. They're more likely to stick to their treatment plans and take medicine correctly. Because if we found a medicine that works best with your lifestyle, it's more likely to be the right one that you're going to be able to adhere to and stay on. And then that's going to lead to the good benefits. It's less likely to cause emergency hospital services, and patients are more satisfied with their care overall. So I hope that's given you a nice overview of the importance of shared decision-making and why it's stressed so much in our guidelines and in our consensus documents. And now we'll hear a little bit about a physician's perspective on shared decision-making. Thank you.
Hi, I'm Dr. Nicola Cooper. I'm a consultant haematologist at Imperial College Healthcare NHS Trust, and I manage the immune haematology program, which includes adults and pediatrics in a transition clinic. We run clinical trials, phase 1, 2, and 3 clinical trials on our unit, and I also run a research laboratory on ITP. Thank you for that question. So I think one of the important parts about shared decision-making is helping patients to understand the different treatment options that they have in ITP. And I think this can be a confusing area. There's lots of different possible treatment options, and they target different areas, so that can be quite difficult. I think the most important thing about shared decision-making is really having the time to be able to talk to patients within that clinical scenario, either in the clinic, the daycare, or in patients. And I think mostly it's about having the time to really discuss those treatment options, which I think is really important. Yeah, I think that's a very good question. And I think one very important thing that I always say to patients is if you have any questions, just write them down and make sure you've documented that somewhere else, so that you know, I think it can be quite an intimidating place coming to clinic, and sometimes you can forget what you're wanting to ask. So certainly writing things down is important. Second thing is bringing someone with you. It's very difficult to remember everything that somebody tells you within that room. I think having a second person with you just can help you remember the conversation, which I think is really important as well. And I think just remembering that this is your time to discuss things with patients, and it can be, you know, it's often a very busy clinic. It can be difficult to have enough time to talk about things. So I think making sure you've written everything down, bringing a note paper and pen with you as well, I think that's really important. Yeah, it's a good question. So I think it can be quite an intimidating time, I think, for patients, particularly in their first journey to ITP. And the patient support group have put together with some clinicians, a shared care decision-making process leaflet, which is available. And there's certainly sort of tools on the Patient Support Association website. So, and I think the internet can be quite a scary place too when you start Googling things. So really go to sort of dedicated sites such as the Patient Support Association groups. Just spending some time thinking about what you want to ask, what's important to you, what are your treatment aims, your goals for treatment. I think those are the kind of things that are quite important. Yeah, I think that's a good question. I mean, I think it's in some ways it's quite confusing for ITP at the moment because there's so many different treatment options, and they all target different parts of the immune system or different parts of pathogenesis of ITP. And we don't have a diagnostic tool that really tells you what kind of ITP somebody has. So certainly within our clinic, we go through all the possible reasons why you can develop ITP and try to explain why different treatments work in different ways. And I think the second thing to sort of think about is that not everyone will respond to one treatment. So sometimes it's a journey of treatment. So there are lots of treatment options and you'll respond to one of them. But it's difficult because we don't necessarily know which one you're going to respond to. So I think it's just about trying to understand all the different treatment options that are there and recognizing or understanding that you might cycle through a number of different treatment options before you come to that treatment. And I think that can be quite confusing for patients as to why you might respond to one or not the other. And it may also be that different healthcare professionals are advising you on different treatment options. And really that's because there's a lot of different treatment options that are available. So I think trying to understand the pros and cons of each treatment, how they might work, and how you might have to go from one to the other. And I think that's not a very easy thing to understand. So I guess one suggestion I would say was that just having a better understanding of why people get ITP, how it works, and that kind of thing is something that we need to do as clinicians as well. Yeah, so I think within our patient information leaflet, we've created a diagram which shows, how platelets are formed, how they're then destroyed, how antibodies or T cells, different parts of the immune system can contribute to that. We're also very fortunate to have some really good and very experienced specialist nursing support. And that's really transformed, I think, the care that we're able to give, because they are able to then talk to the specialist nurses, they're able to communicate with them between clinics. And I think that's been very helpful, so that you're not just stuck with that one sort of short period of time, the doctor, that the nurse can continue that. That's not available everywhere, but certainly I think that there is an increasing education. We are providing more education, and a number of groups are doing that to nurses so that they can provide some of the extra and additional support for patients, and perhaps easier to communicate with.
Thank you very much, Dr. Nicola Cooper. As you will all be aware, Dr. Cooper is also a medical advisor with both the PDSA in the USA and the ITP Support Association in the UK and Ireland. I'm sure, Lochner, you found some of the insights and the helpful tips very, very useful for today. We're now going to expand on this a little further by moving over to Barbara and Danielle to gain a patient perspective and experience on shared decision-making in ITP care. They'll begin by taking things back to where it all started, from when they were first diagnosed. Over to you, Barbara and Danielle.
I was diagnosed with ITP when I was 4, and I was just a child. And for me, it was really very traumatic experience, and also for my family. Even though I was really a small kid, I still have a very vivid memory of that moment. I remember my mother crying, and it was very difficult for all of us at the beginning. After first time I was hospitalized, it seemed that my ITP was cured. But then after my relapse and my ITP became chronic, and for my parents and for me, it was really very difficult to find a balance between ins and outs from the hospital and all these platelet fluctuations. So yeah, it's a long way. For me, it was it's a long time that I'm living with ITP.
I think for myself, I was actually diagnosed 8 years ago. I was lucky that I presented at the local emergency department of my hospital, and for chest pains of all the things in the world. And they took a random blood draw and told me that I had a low platelet count, that I possibly had ITP, and to come back on the following Friday. I came back on the Friday going, yeah, whatever, like this is not really anything to worry about, and ended up being hospitalised for a number of days. It was actually my son's 12th birthday. I remember it quite clearly, and yeah, it was quite a shock to the system. I was a young, healthy, fit woman but I'd been experiencing bruising, bleeding gums, a lot of the symptoms for a very long time, but just thought that it was me. I bruised like a peach. I just, it wasn't much of an issue until I was diagnosed. But I was lucky I was diagnosed by one of the best in Australia. So, yeah, it was quite a shock to the system.
The change actually is quite recent, because it's after TPOs 10 years ago became a treatment option for us. Actually, some things started to change. Especially further change, well, I noticed further change after the quality of life issues of ITP patients started to be addressed. When ITP becomes chronic, the relationship between you and your physician is very important, and it's a very important aspect of the care. But until we actually started to look into the real burden of ITP, and there were no 15 years ago or 20 years ago, we really had not so many treatment options, and there was not much to discuss with your physician. You were just trying to survive and trying to find some kind of a balance. So yes, last 10 years, and every year I can see improvement in this field. So new treatments took us to talk about what is quality of life, what are side effects, and all the other things that actually are part of the care of the patient.
I completely agree with you, Barbara, there. I have to completely agree. When I was first diagnosed, I didn't know what I didn't know. So I was really relying on my doctor to provide me with the right information. And I'm lucky that I had such a great clinician. Even just a couple of weeks on steroids, he saw me and saw the excuse my language, the basket case that I'd become, and just went, that's it, let's pull you off. You are not okay. And that for me was really, it was really lovely. It was really wonderful. But it was only a couple of years ago, after talking about quality of life, that I started to see it really trickle into not just my clinician, but right across Australia with the healthcare system and those sorts of things. Yeah, there's still pockets that it's still becoming available, becoming part of the norm, but it is definitely improving, and there's always going to be room for improvement, especially when it comes to shared decision making. It's an education, it's a process, but there's definitely improvement.
Yeah, one of the things, sorry, Danielle, if I continue after you, there is a really big difference in how you are treated by physicians that have big experience with ITP compared to the physicians that don't understand what having ITP is. So this space for improvement is really, really huge.
It's true. And being a rare disease as well, we can't expect the clinicians to know absolutely everything about all of the developments either. So, and that's why it's important to have a shared decision making, because as patients, we learn so much more about our disease. So it's got to be a two-way street, right?
I don't think if this actually is the perfect example, but I think it is. Because as a child, I was not able to decide anything. I was just, at that time, actually, it was not so usual to ask patient preferences anyway. And there were not lots of treatments to choose among. But I know that my mother was not informed about ITP, because at that time, it was not easy to access all the information. And it's not easy to learn like we can learn today. And in order to be a part of the shared decision making, you have to be informed. And that's why the patient associations are very important. My childhood experience actually is a perfect example how you feel when you are not a part of this of making that decision. You just feel like you don't know anything about it. You don't like some treatments or some options that you have to go through, but you don't have voice. You just feel like an object, not like a person. You feel powerless, and don't see your needs satisfied, and actually the message you receive is that your needs are not important, and it is really, you feel ignored, and it's really frustrating. I don't know, Danielle, if you agree with that.
Oh, I definitely agree with that. I've had, I've spoken to patients before that have had some really horrific experiences where clinicians have told them, well, you've got to have this treatment or you can find somebody else. And, that shocks me. It really shocks me that it's still happening. That sort of stuff is happening today. But on the personal experience, I really early on in my diagnosis, and this wasn't my clinician, it was somebody else that had sort of come in left of centre. I was on steroids. At the time, I had aches, in every joint possible. My husband was having to carry me around the house, and my doctor, I called the hospital, and the doctor who answered and took the call turned around to me and said, look, don't be so silly. You're fine. And I was completely dismissed. So it wasn't a conversation. It wasn't, I just felt stupid, and like I didn't know what I was talking about. Whereas my existing treatment is the complete opposite. So, you see it all the time, and it's disheartening to see it, but even from a child's perspective, I think it's really important that we, incorporate and consider and, involve them in the discussions and talk about things like side effects and, how's that actually going to impact me as a patient, and, what's that going to mean when I leave the hospital or leave my appointment? How's that really going to impact me as opposed to what I've been told how it's going to impact me. So I think that's really important as well.
Well, when you feel that chosen treatment is a part of open discussion, and you feel it like it's also your choice, and that's you're really motivated to make it work, and you find a way to stick with it, because sometimes it can be challenging to stick to your treatments. And especially if they require some restrictions, or you have to go to the hospital frequently. So yeah, it really helps you to stick with it and to make it work. For me, the most important feeling is that actually I'm doing something that will make me better, and that I'm taken in account as a person. And I feel respected and not powerless, in a contraposition when you are not part of the shared decision making. Actually, I had a really bad relapse in 2018, and I was suggested to start with TPOs. And I was not very happy with that, because side effects that were related to bone marrow were quite frightening for me. But I have to say, as Danielle, I have a really excellent hematologist. We discussed all of it. He took all the time. I needed to actually put aside, my emotional part and turn my rational brain on and understand the figures and understand what he was doing, because side effects, the probability or how much is it, how big possibility there is that you actually have that side effect, understand that figures, it's not quite easy, but when you are afraid and in fight or flight mode. So yeah, that's very important that you have someone that understands that you have your emotional part, but certain things like side effects and probability to get affected by the side effects, you have to have your rational brain working on. So it has to be a teamwork, but it's actually thanks to this effort from my physician, I started using this treatment, and it actually helped me.
I agree. Having that shared decision-making process and having that consistent dialogue with your doctor, it empowers you as a patient. It validates how you're feeling. I know personally I experience anxiety, and I've had a discussion with my doctor and say, okay, so let's not start with my platelet count. Ask me how I'm feeling. How have I been these last couple of weeks or this last week? And he's really taken it on board, and he's my doctor. That's how he starts the conversation. That's how he starts the appointment. And he listens to my side effects. He listens to some of my concerns. I was, a couple of years ago, it was Christmas season. We're all letting our hair down and having a little bit of fun. And I mentioned, I asked the question, is alcohol a big issue? He said, well, what's it? That really depends on you. That depends on how you're feeling, and it's as individual. The side effects and the impacts are as individual as what it is to somebody else. So you do you, and I found that quite validating, and it made me feel like I was part of the conversation, and it made my shoulders sort of fall, and really build that relationship and continue that relationship that I've got now with my doctor. So same with my GP. My GP, I've been educating him over the last couple of years with regards to ITP, and he is constantly asking questions and what about this, and have you considered this, and and talks directly with my haematologist as well to make sure that it's a shared decision and shared discussion across all of the different aspects of my health. So everything is, we're all working towards the one goal, which I think is really, really important.
For me, it's very important to be and to prepare myself for the appointment itself. Especially, I already know a lot about ITP, but if there are some new treatments or I have some new symptoms or new questions, I really try to make sure to make all those questions and to ask about new treatment options. So for me, that's really important part of shared decision making. If between appointments, I do have things that cross my mind or I would like to discuss. I'm a little bit old-fashioned, and I like paper, notebooks, and stuff like that. So I write them down on the paper. But there are also beautiful apps or other possibility or other tools that give you possibility to write down actually what you want to discuss. It's really important to ask all those questions and not to fear to seem stupid or too annoying. And it's also important that correct communication, that there is a correct communication between you and physician. And you have to ask until you understand. And this is, I'm like that on my nature. I always ask until I don't understand. And I'm not afraid doing that also in my physician office. And there are some other people that are actually not like me, but you have to find your own way, because this is something that will help you get a better care.
Yeah, I think you're right there. For me, I write questions in notes on my phone if I'm out and about or whatever, and I think of something straight away. That way, because I've got a memory like a sieve, and I can never remember everything when I walk into an appointment. If I don't understand something, I constantly ask questions until I do. I just ask for plain speak. Stop talking to me like I'm a doctor. I don't know what you're talking about here. My doctor draws diagrams for me at times as well, which is actually quite helpful. I'm a visual person. I actually ask him to spell words for me as well, so I can go back home and have a look at those words and learn a little bit more about my own disease as well. And I just take the time, and I ask him to take the time to, instead of that 15 minutes, you've only got this allocated amount of time. It doesn't rush me, and I also don't try and rush him either. I think it's and I think I've also taken, as much as I love my doctor very much, I've taken him off the pedestal that we all just assume that all doctors know everything. They don't, and he can't read my mind. I can't read his mind, so I ask the questions. No question is a stupid question. There is no such thing as, these guys have done years upon years upon years of education. We haven't, and every question is valid. It's really valid. So whether you're using an app, voice messages, you can email your nurse or talk to your GP, or having that constant dialogue and that ongoing dialogue, I think, is really important. It helps to grow that relationship and nurture that relationship that you have, and which will only improve your treatment.
As I said before, attention, that actually we have that emotional part, and then we have that rational part. This is something that I know it's hard, a lot to ask for physicians and hard to do, but actually, understanding with which part of ourselves we're communicating in that moment, it's quite important, because the response of the physician or how they will present what they need to discuss with patient changes. And asking the patients if they understood what was explained, asking them if they have doubts, if they have preferences, how they feel about treatment they were discussing about. And it's also very important to understand that we patients, we sometimes need time to digest the information we received. If there are lots of things that were discussed during the appointment, it's very useful maybe to reach the patient a few days afterwards to ask if they have other questions or they need some other stuff to discuss. Because when you receive lots of information, you just get overloaded, and things need time to settle down, and then new questions arrive. And so this contact after a few days after appointments is very, very useful.
Yeah, I think you're right there. And I think the important thing is to not just hear your patients, listen to your patients, really understand, as Barbara mentioned, I know personally I'm an emotional person, and when things are terrible, I'm an emotional mess. I feel so sorry for my doctor when he has to see me when I'm not at my best. He's really calming. He uses plain speak. He talks to me calmly. He also encourages me to bring a support person, because if I can't hear everything and I don't have the capacity to absorb everything that's being said or discussed, he generally says bring somebody along, because that person is not in that emotional situation, and they're more likely to be your rational side, so you can recall, you can go home, you can digest, you can just discuss, and making sure, especially when somebody is not necessarily responding well to treatment, check in, but also make sure that they've got somewhere to reach you if they've got to reach. If something goes terribly wrong, terribly quickly, what's the plan? So then that way they've got that reassurance that if something does go bad, if something isn't working, that there's a bit of a safety net there for them as well. And just having that open dialogue, which is really important, and plain speaking.
Take time to prepare for your appointments. Time is precious resource for you and also for your physician. And getting prepared will get you to get the most of that appointment. And, ITP brings lots of anxiety and stress in your life. And even small things like getting prepared in order to know that you will address all the doubts and fears that you have will take away a little bit of that anxiety that you have. And if you actually have difficulty in connecting with your physician, that's fine too. But you have to address that issue too in order to fix it with your physician. But if you truly can't get that connection and support you need, maybe you should consider also finding someone else, because ITP has lots of impact in our everyday life. And I think that we as patients need to do whatever we can to relieve a little bit this burden of ITP and be the part of the most active part of society that we are in.
A couple of tips for me would be remember that your doctor can't read your mind, and you can't read theirs either. So having that open dialogue and that honesty is there. Be honest about the way you're feeling, because if they know that you're experiencing any anxiety, side effects, then they can help you fix it. Even if you think it's really, really small, it's okay. You're not the first person that they've seen, and they're just there to help. They are really there there to really help. And I think be kind to yourself and be kind to your doctor as well. If they're running late, you don't know what's happened in the background. Be kind. They are running 1,000, more often than not, they are running 1,000 miles an hour. So be kind, but also be kind to yourself as well. I think that's one of the biggest things that we don't do enough as patients.
Well, thank you so much, Brendale. Two wonderful women who are doing incredible work of educating and supporting ITP patients and families in Italy and Australia, but also part of the International ITP Alliance. And thanks to the both of you for being so open and honest and sharing your personal experiences with us today. I'm sure you may be able to relate to the moments shared by both Barbara and Danielle. I know I dealt with some of the same feelings and fears, both physically and emotionally, when I was living with chronic ITP. So we hope the top tips will be useful to you to put into practice yourselves. I know at pdsa.org, we have a list of questions and comments starters for you and your doctor. And I know Mervyn has a lot of resources on his website as well. So now, following on our expert speakers, we thought it would be a good time to go through a couple of live polls to gauge how your ITP care has been so far and whether decision-making is prominent in the poll. And the question is, do you feel like you're involved in decisions about your care currently? Yes or no? Mervyn, we're going to give it a few more minutes for more people to respond, because right now it looks like only 6 people out of 6 have responded, if I'm reading this correctly.
We need a few more, I think. So, yeah.
Obviously, these are people who are very active in their care and shared decision making, which is really great to see. But we also know that there are patients out there who don't feel supported.
The poll's ended now anyway, so no one says no, which is amazing. I'm absolutely amazed with that. All the people who responded say yes, they do feel like they're involved. That actually goes against, some of the findings we've had in various surveys that we've done in recent years. I don't know about you, what you feel on that, Caroline.
Oh yeah, no, I absolutely agree with you. So I guess we'll go to the next polling question. And the question is, have you ever used a discussion guide to support you in your healthcare appointments? Again, please cast your vote, yes or no.
Okay, that poll's ended. 30% say yes, they have. 70% say no, they haven't. But bearing in mind, I know in the UK discussion guides are relatively new. I suspect you've had something in the US for some time, Caroline.
Actually, we haven't, and I know Mervyn.
Right.
We talked before about this. We have information again. We have a toolkit on globalITP.org. But in addition to that, I know Mervyn, you have a discussion guide and other resources.
Yeah. We actually did the ITP discussion guide in collaboration with SOBI, and that was launched last year. And it's been very successful, going out around lots of the haematology departments in our hospitals in the UK. So we are quite pleased with it.
Yeah, and as I mentioned, while we don't have a discussion guide, we do have a list of questions and suggestions to help you choose the best doctor and treatment to manage your condition. And you can find that on pdsa.org as well.
One of the one of the participants actually put in the Q&A about this because of the number of people who said they do shared decision making, and the answer was maybe the people on this Zoom are already quite involved, which I suspect they all are, because we normally find the people who want more information about ITP are already fully up to verse with it. So yeah.
Well, we are recording this webinar today, and we will all make it available probably on YouTube and on the ITP Support Association website and the PDSA website and globalITP.org as well. So please feel free to share it with your ITP patients and families and let them know that this resource is available for them as well.
But just going back to the first question again about people being involved in decisions. In reality, it is exactly what we wanted to see. Because shared decision making is very important, and it's crucial to ensuring that everyone's happy with their care that they are receiving. For those of you who voted no, and there was none, thank God. You must know all the tips from Dr. Nicola Cooper and all the advice from both Barbara and Danielle. So I'm really pleased with that.
So we have about 6 minutes left for this webinar. And if anyone has a question, please put it into the Q&A. I think Mervyn, Dr. Nicola Cooper is going to be joining us, and she can answer world-renowned ITP expert. So now's your opportunity to ask a question of a world-renowned ITP expert.
Welcome, Nicola.
Hello.
Hiya. Right. Doing well. Yeah, doing well. Thanks for joining us today.
My pleasure.
We have a question for you. We've heard from Barbara and Danielle about top tips. Do you have any more top tips in addition to what you've already shared with us earlier in the video?
Yeah, I think the most important thing is either bringing a notepad or a person with you. So I think that, it's quite hard in that stressful situation to remember everything that you say. And I think sometimes people can be quite emotional, especially the first time they visit a new center. It can be quite a scary place. So I think bringing someone with you is really important, and writing things down. So having a notebook, maybe keep one particular notebook that's relevant for your ITP and do that. And I think, using all these kind of tips and the PDSA and patient support groups, just sort of information from there, so you can feel like your understanding of it. And I think, as I also said, it's like, the Google and internet can be a scary place. So I think some of the other points that were brought up were really important as well. We are always busy, we are always overlaid, and try to focus on your ITP rather than how frustrating the whole system is, I think, because it's difficult. It's a horrible time to have to try and wait for maybe a couple of hours to see someone. So I think just sort of focusing that the ITP is the thing, and that's the problem rather than the system that can frustrate all of us, I think.
Okay, thank you.
Yeah, those are great tips. And I think especially bringing someone with you if you can, because I think sometimes we interpret things a little bit differently than somebody else might. You hear it one way and they hear it another way, especially, as you said, if you're, anxious or scared about the situation. So we have another question here. Should I take the decision guide to the doctor or memorize it?
I think you can take it with you. Absolutely. I think that's very hard to try to memorize it, but I actually think taking it with you is a good idea. I think recognize that if it's the first time the doctor has seen it, that you might need to leave it with them so they can have a think about it too. So just be sort of patient with the process, I think. But certainly I think I would take it with you, definitely.
Okay, excellent. Another question. Do you have any tips for how to ask your doctor about starting the shared decision-making process about treatment, actually getting that conversation going?
Yeah, I think bringing someone with you makes the difference, because I think sometimes when the relationship gets a bit heated, it's because everyone's stressed, and actually trying to sort of bring not feel emotional about it. I kind of feel like that's sort of coming from a possible conflict kind of thing. And I think everybody wants to achieve the same thing. So I think it's just being something I learned about conflict is curious. Say, I'm curious about this, perhaps, that might be a way of opening up the conversation. I'm very curious about this new thing that I found. Is this something that you might be interested in looking at? That sort of makes the conversation an open conversation instead of starting it with a conflict, if that makes sense. Because I think sometimes when people are very stressed, it starts out being a conflict, and it shouldn't be. There's no reason for it to be a conflict. So just sort of thinking about it that way. Look, this is a curious thing. This is something I found. Is there something possibly you use? And then that brings everybody into the same place, I think.
Thank you. Caroline, do you want to do the next question?
Sure. What is the practical advice or tips if my doctor does not know or does not understand shared decision making? And I think the three of us know from working on various surveys over the years that sometimes the physician perspective is quite different than the patient perspective.
No, I think that's very true. And I think that, just sort of thinking even with my own practice where we, sometimes the problem is that we're very rushed and sometimes everyone's very tired. And I think just, again, trying to make this about a discussion rather than a conflict, or kind of, you don't know this or you don't know that, or why aren't you doing that? So I think trying to think of this as a dialogue is one way of doing things, and perhaps sort of leaving that information with them. I think, if you are really struggling, if you're not getting anywhere with your doctor, I think that approaching, in the UK, Mervyn, or in the PDSA yourselves, sort of about, are there other ways that you can, do you need a second opinion on that, and exploring that. But I think the first thing I would think about, and I think, it was discussed really well during this session, I think the clinical situation is often a very stressed, sort of very rushed place, and being patient with the process, going in with an open mind, believing it's going to work, and thinking, well, let's actually try to have this conversation. And it might be that the doctor doesn't have time for it then, but actually might have to make a follow-up meeting with you later to discuss it. So just being mindful that sometimes if it's a difficult consultation, it might be about something else that's going on in the clinic in the background. So not thinking they're a bad doctor, but actually perhaps they've never seen that before. They might need a bit more time to think about it.
We've had patients tell us that they've taken articles or studies that they've seen either in our newsletter or on our website, let's say about fatigue or maybe a new treatment, where their doctor just wasn't that educated, right? Because they don't see that many ITP patients. And so the patient told us that they took that information into their doctor and shared it with them. And Mervyn, I know you also have a lot of great information in your newsletter and on your website. So I guess that would be a suggestion from me.
And me as well, actually. Yeah. And another good question that actually hits home is based around your last answer. Is there a good way to ask for a second opinion to make sure that the patient is making the right decision?
Yeah, absolutely. Ideally, I think you do that with your doctor. So the best situation is that you ask your hematologist for a second opinion, because that way it's a proper two-way conversation. And I would never be offended or upset if someone wanted a second opinion. Good. And I don't think doctors shouldn't be upset or offended by that. And it makes the process easier if you can involve your hematologist. In the UK, if you really are getting a barrier to getting a second opinion, you can ask your GP. So the GP can then refer you to a sort of second opinion. But certainly I think that, you should be able to ask for a second opinion. And I think bringing everybody into the conversation makes it easier. If that's possible, but certainly discussing it, I think, with the GP, or certainly with patient support groups. I think, Mervyn, you get a lot of questions as well. I know that, and Caroline, you do too. And I think sort of bringing in other people to help you to deal with that. And again, so trying to make sure that conversation is an open conversation rather than a confrontation on either side, actually, because I think it can get difficult, I think, but not because people don't want to help. Sometimes it just becomes frustrating.
Okay. There's another question, I think, because time's coming on now. So the last question, doctors, particularly in the UK at the moment, are under lots of stress.
That would be in the US too, Mervyn.
And the US too. Excellent. And I suspect it's everywhere around the world.
Yeah.
What can patients do to make their life easier?
Oh, thank you. No, I think that's really true. And I think recognizing that if we're late for the clinics, you're having to wait a long time, really, we're just as frustrated as you are for that situation. And just everyone just needs to be kind to each other. I think, it's been a very difficult time in the world in general, hasn't it? And I think just remembering that, you don't know what else is going on in anybody else's life at this time, and just trying to be kind, really, and just making sure you're just sort of recognizing some of the frustrations that are inherent in healthcare and in the world in general, and just trying not to make it a difficult sort of conversation, I think, really.
Excellent. Okay, thank you very much, Nicola. Thanks for your time today. Thanks for your presentation earlier and also answering the questions. That's all the questions we've had time for today. But thank you so much to all of our expert speakers for taking the time to share their knowledge and insights with us. And of course, to you all for joining us today and taking the time to participate. We hope you found the webinar useful. We will be sharing the recording of this, as Caroline's already said, afterwards, so you can revisit our talks by our guest speakers at any time. Thank you so much again, and wherever you are in the world, have a great evening, morning, night, anything you like. Thank you. Bye-bye.
Bye-bye.